Right, so close to 8 million South Africans are living with HIV, making the country the epicenter for the disease globally. The bulk of infections are in KwaZulu-Natal province. With the rise in new infections after the COVID-19 pandemic and the burden remaining on young women in sub-Saharan Africa, scientists, NGOs and policymakers will be in Durban at the 11th SA AIDS conference starting tomorrow to reignite a multi-stakeholder approach in fighting HIV. So for more on this, we're going to be joined via Zoom by Dr Thato Chidarikire, who's also acting head of HIV/AIDS at the National Health Department and conference co-chair. Very good afternoon to you, Dr Thato. Thank you for your time with us here on the SABC.
Good afternoon to you too, and good afternoon to the listeners. Thank you for inviting me. Thank you.
Perhaps we could speak to the reality on the ground for South Africa and how we're faring in terms of tackling HIV and AIDS to date.
So to date, we can say that we've been tackling HIV for the past 40 years, almost 4 decades. And while we have made some strides, actually positive strides towards, what you can say winning, but we still have a lot of work to do. Will take us to our UNAIDS targets, our 95, 95, 95, where we're supposed to have reached by 2025, 95% of people living with HIV knowing their status, 95% of those who know their status being on treatment, and 95% of those being virally suppressed. As you said, we have just about 7.9 million people living with HIV at this point. About 5.7 million of those are on treatment, and we are trying to ensure that they actually are virally suppressed. Just over 4.5 million are virally suppressed. So while we can say we have made great strides, we still have a lot to do, especially in terms of initiating people on treatment and making sure that they stay on treatment.
Absolutely. No, absolutely. And thank you for that context. We also saw that a lot of funds meant to tackle HIV and AIDS were diverted to deal with the COVID-19 pandemic and the height of the pandemic. How has that affected the sector, and what progress has been made to ensure that we are back on track as we give it the attention it needs?
So the department has acknowledged on many platforms that COVID-19 actually reversed the gains that we had made in terms of HIV and AIDS, TB, on the many years that we have been fighting this epidemic. And when COVID-19 came, we had to actually just leave everything and work towards fighting this pandemic that came and was just really making, increasing morbidity and mortality in terms of everyone. So as we know, if we look at early 2020, we had hard lockdowns, and that is what caused a lot of challenges in terms of access. And especially for the population living with HIV who couldn't access their treatment, who could not access, I would say, their medicines, and could not really get into the clinics because of the hard lockdowns. However, once we managed, as health to work around what to do in terms of managing COVID itself, we lessened the lockdowns, and a few of the regulations were less hard, and people were able to go to facilities, even though clinics were not necessarily closed, because one would remember that facilities would be open because they provided essential care. But the problem was transport during the hard lockdowns. So people were not able, that's why I talked to access. However, also because the nurses would get sick, when people got sick at the time, then we would close and sanitize and clean up. So those were the challenges that actually became barriers to access to public health facilities.
Let's look at the strides that have also been taken, which you alluded to earlier on. There's also been a lot of advances made in treatment, especially with children. Perhaps you could talk to us about the latest advances and who's eligible at this point to undergo the treatments on offer.
Right, so we have just published new updated ART guidelines, treatment guidelines for both adults and children. And maybe let me start with the adults, where I will say that what we are trying to do is to move or transition all the patients from what we call TEE, efavirenz-based regimen, to TLD, which is a dolutegravir-based regimen. The reason why we're doing this is that dolutegravir, which is really the drug to go to in this case, is actually beneficial. It has a high genetic barrier to resistance. It has good tolerance in terms of actually resistance as well. And being in a fixed dose combination, one takes it once and they're able to actually manage HIV. It also really manages viral suppression quite quick. So we are moving or transitioning clients, adults, from TEE to TLD. And then when it comes to children, in 2022, last year, we also published a circular that children can also be now moved to DTG, which is dolutegravir, ARV, which is, again, I have mentioned the benefits of dolutegravir. And for children, it is actually children that are 3 kgs and over 4 weeks as well. That can be put on dolutegravir-based regimen. And then with adults, everyone who takes treatment naive, who is new on treatment, will be put on dolutegravir. We're actually saying that, what used to be called first-line regimen?
Yes.
We're now going to be calling it TLD1. And then one would know that if patients failed on first regimen, they would be put on second regimen, then even move over to the third. So we're going to have now TLD1, TLD2, TLD3, meaning all the 3 regimens will be actually containing dolutegravir because of, as I said, the high genetic barrier to resistance.
Yes.
So if clients fail on treatment, what you're going to look at is adherence rather than resistance.
Dr. Thato, I'm sure these and other options are going to be explored throughout the conference. Very quickly, in the interest of time, we've got the NHI that's obviously in the news at this point, and we're looking how this is going to affect HIV/AIDS patients as well. Do you think this is the way to go to make sure that access is granted? And then also wanted to just look at the stigmas attached to HIV and AIDS. Have they been dispelled? Have they waned over time? Help us to understand how we're managing on that front as a country as well.
As time goes, I wouldn't want us to undermine stigma because it's still rife. It may be getting better, but it is still rife. So we still need to really work together to ensure that we do combat stigma, because it is one of the reasons why patients do not go and test for HIV, and why people do not stay on treatment, and why people do not normalize HIV, which is really now a chronic disease rather than what it used to be, which was a death sentence. So when we talk about NHI is about universal access. And I'm sure we're all aware of the processes that are now in cabinet and all the approvals of the bill. So what now this means is that because HIV, carries such a big portion of healthcare, it will be part of NHI because, as we say, we really wouldn't be able to take care of primary healthcare if we don't integrate HIV.
Dr. Thato, thank you for your time with us here on the SABC. Dr. Thato Chidarikire is just weighing in on the head of the 11th SA AIDS conference taking place between the 20th and the 23rd of June.